So let's start from the very beginning. Okay, so we're going to discuss the molecular journey and put it into comparison to the journey that has been experienced in relation to clinical chemistry. So in 1825, William Tract identified the application of analyzing bodily fluids as an indicator in health. So this is 200 years ago. And a few years after that, the first correlation between water retention and albumin was made in urinalysis. Then in 1850, the introduction of chemistry in practical diagnosis was implemented within St. George's Hospital in England. And it wasn't until the latter part of the 18th century that the term clinical chemistry was first coined in a medical journal. Now, put that into context with regards to molecular. It was 1983, so around 150 years after William Prout's identification, that the invention of PCR took place. And the first application of PCR as a diagnostic tool occurred in 1987. And this invention, this discovery of PCR was contributed to Dr. Kary Mullis, in which a Nobel Prize was won. In 1993, the creation of real-time PCR was invented, and this meant that the quantities of PCR amplicons could be determined. And then more recently, back in 2019, the terminology PCR became very commonplace and widespread due to the COVID pandemic. So we have now entered the new era of point of care, and this is very much evidenced by the fact that the international guideline ISO 22870 has been withdrawn and is now incorporated and amalgamated into the 4th edition of the International Standard 15189/2022. And this international standard is the regulations that are required for quality, laboratory quality and competence within all different types of labs, may it be clinical chemistry or molecular microbiology. And as said, this also incorporates point of care testing for all of the testing incorporated within molecular. So there has been an increase in the prevalence of infectious disease testing, which has been catalyzed in most part by the SARS-CoV-2 pandemic. And as a result of this, a lot of the testing for PCR has vastly improved, and the performance characteristics of PCR has immensely improved. Things like the sensitivity, specificity, improved limits of detection, and also a more dynamic improvement of the analytical measuring ranges insofar as the viral load testing. So there was a report conducted within the review of NHS Pathology Service in England, and they have, if it hasn't been read yet, I recommend giving it a read. But it states within this report that a greater standardization would help to reduce the fragmentation of services using a combination of lab and point of care test systems. So what is clear, however, is that these developments in near patient testing must be safe, accurate and foolproof. And this really is a definition of what our Vivalytic point of care molecular platform can provide to labs whenever implementing a point of care platform. The Vivalytic, shown here on the right-hand side, alongside 4 of its well-established syndromic panels, is a cartridge-based point-of-care molecular analyzer. The machine performs all the required steps of a molecular workflow within one contained unit. You've got your extraction and purification of nucleic acid, followed by the amplification of target nucleic acids, And finally, the detection, analysis, and interpretation of the patient result. This is all done automatically within the Vivalytic platform. The Vivalytic has been designed for use within centralized and decentralized environments, may that be the core clinical lab or point of care environments such as GP physician offices or nurse ward stations within a hospital. The Vivalytic Analyzer is a small, compact point of care platform. It is 400 millimeters tall, 388 millimeters wide, and 204 millimeters in dimension. The result time ranges from as little as 30 minutes to 150 minutes, depending on the panel that the physician has ordered. So some of the low-plex platforms that contain maybe 1 to 2 to 3 analytes can provide a result within 30 minutes, whereas the more comprehensive syndromic testing that can detect up to 20 different pathogens simultaneously take up to 150 to 200 minutes. The levels of precision are impressive and are very high and are clinically relevant. The testing process itself is extremely easy and user-friendly, and the analysis aspect of the platform allows easy interpretation of the patient result. The advantages of the Vivalytic are numerous. The Vivalytic Analyzer is intuitive, it's easy to use and easy to handle. It's very easy to transport and it's portable. It is a lightweight unit with no additional pieces of equipment such as a barcode scanner or a keyboard or a screen, as all these components are integrated within the Vivalytic itself. With its compact dimensions, the Vivalytic Analyzer is small and can be placed anywhere within the lab or hospital ward. It is universal. The technology that is present within the Vivalytic is based on the biochip array technology, which is a medical grade biochip microarray that can produce qualitative results for large syndromic panels, as well as small low-plex quantitative PCRs, which provides amplification plots and melting curve analysis depending on the panel which you choose to run. The results are made available immediately, both the clear summary and the raw data of the measurement. For efficiency and convenience, the analyzer can be both integrated into existing IT systems and connected to other analyzers. So it allows customers to install multiple different Vivalytic platforms, but utilize one of the platforms as the mother unit to use that image, to choose that unit as the main testing platform. The Vivalytic is a highly secure IT piece of equipment, and the data protection standards that are present within the Vivalytic guarantee the effective and reliable protection of the data that is contained within the Vivalytic unit. The Vivalytic may be only one device, but it has multiple benefits. We offer a unique test menu. The panel and the platform is fully automated. The platform conducts all required molecular workflow components from extraction right through to detection. There offers the capability to run low-plex and high-plex testing. For example, low-plex respiratory, high-plex respiratory, low-plex STI, high-plex STI. The unit is also wireless and LIMS connected. The total storage is 16 gigabytes. That is equivalent to more than 1,500 patient test results. We have the second largest test menu available in the global market. The results provided to the lab professionals and clinicians are fast and competitive from as little as 30 minutes. All the reagents are located on board within each single-use cartridge, and it is important to note that no cold chain requirements are needed. All reagents are contained and can be stored within ambient room temperature. The fully automated is complete within a 4-step workflow, which I will talk about in more detail over the next few slides. Step 1 of 4 is to scan the sample code. Step number 2 is to scan the cartridge code. Step number 3 is to fill in the sample and close tightly the cartridge cover. And finally, step number 4 is to insert the cartridge into the mouth of the Vivalytic. The cartridge will insert automatically and the test will commence immediately. Randox and Bosch have an established partnership that utilizes the best of scientific know-how from Randox and the best of the manufacturing capabilities from Bosch. And these two qualities have been merged together to create the perfect all-in-one molecular solution. The main features of the Randox-inspired cartridges include the addition of a single 9x9mm Randox biochip. Each of these biochips that have been incorporated into the cartridges contain up to 49 discrete test regions. These test regions have oligos tethered to each of them, and after the PCR process, the amplicon, if present within the patient sample, is hybridized onto these discrete test regions by a process known as DNA hybridization. One sample is added to one cartridge and up to 49 discrete test results can be provided. This partnership utilizes the R&D of two companies, which has created very fast growth over the last number of years. For example, in 2021, we had 2 tests available within the Vivalytic. We had the single-plex SARS-CoV-2 test and then the double target SARS-CoV-2 test. And these tests were very well utilized within the UK, Ireland, the European Union, and further afield for the screening and detection of SARS-CoV-2 during the COVID pandemic in a wide variety of different clinical and non-clinical settings. In 2024, there are 12 test panels available, with a further 4 test panels available as research use. I'll speak about these other panels briefly, and I'll go into the UTI panel in more detail. So no other manufacturer has released so many tests onto a PCR point of care testing device in the last 3 years. And that is something that we at Randox and Bosch are very proud of. And here is a range of different tests, that 12 tests. You'll see they're wide and cover gastrointestinal, respiratory, sexual health, hospital-acquired infections. And these have been released and are now being utilized across multiple markets in clinical labs and within the point of care. The application of these tests vary widely, but most commonly these Vivalytic platforms are most suitable for hospital microbiology and virology labs within the centralized department, but also within decentralized laboratory environments such as pharmacies, GP settings, mobile testing services, and also places like elderly assisted living nursing homes. So you've got your GP clinics, hospitals, nursing homes, pharmacies, STI clinics, and also cruise ships. We know that sometimes in contained places, such as cruise ships, respiratory pathogens or infections like the norovirus can be passed on quite easily. So we do also have the Vivalytics commissioned within several cruise ship companies throughout the globe. The Urinary tract infection testing panel. This is the world's most comprehensive point of care panel for UTI testing. It is a PCR-based assay for the simultaneous qualitative detection of UTI bacterial pathogens covering gram-negative and gram-positive. No long waits or uncertainties associated with the traditional culture method. By utilizing the Randox UTI test, we provide a more streamlined process which ensures accurate UTI screening results for the right treatment to be implemented. We'll show you in a little bit more detail the targets that we have selected to be deemed important for UTI testing. There are a total of 10 targets that are gram-negative. There are 6 targets that are gram-positive species, and we have 7 targets that are related to antibiotic-resistant genes. And these cover 3 major types of treatment, including trimethoprim, methicillin, and vancomycin. The UTIs are one of the most common bacterial infections worldwide, affecting 150 million people each year. This is a huge proportion of the population. One of the main reasons for hospitalization, and it's exhibiting increasing antimicrobial resistance. UTIs are caused by both gram-negative and gram-positive bacteria, as well as certain fungi. The clinical phenotypes of UTI are heterogeneous and range from rather benign to very complex infections and severe urosepsis in severe circumstances. So in the United States, for example, there are over 100 million complicated UTI cases per year. Women are at a higher risk of developing an acute or recurrent urinary tract infection, with about 40 to 60% of females experiencing at least one UTI infection in their lifetime, and a quarter of these experience recurrent UTI infections within the first 6 months. So this can be quite a poor quality of life for anyone that is suffering from recurrent UTIs every few months. A risk factor for developing a UTI is a catheter placement. So those who are immobile, those that are unable to pass urine naturally, these individuals will be at an increased risk of developing a UTI. One study by Coves showed that about 40% of infections in healthcare settings are UTIs, in which 80% of these have been triggered by catheter placement. So you're looking at those in high dependency units, the patients in intensive care units, the very, very young, and those elderly people, and those who are immobile would be most at risk of an infection caused by a catheter placement. Common in healthy elderly men due to an untreated prostate enlargement, with around 94 million cases of benign prostatic hyperplasia in 2019. So yes, women do account for most of UTI infections, but you will see that it certainly does occur in men as well, especially those with prostate issues. The accurate diagnosis and evidence-based treatment of UTIs will lead to better clinical care, a better antibiotic stewardship, and that's really important to limit unnecessary antibiotic use, because over time these pathogens can become resistant to the antibiotics that have been created to kill off the bacteria. The prognosis of UTIs is good if diagnosis and treatment are given promptly and sufficiently in a timely manner. Symptoms can be very serious to patients, especially those who are elderly, those who are young, and those who are immunocompromised, or those who are on immunosuppressant medication. And without this accurate, timely diagnosis, this can lead to more serious complications. And a worst case scenario, urosepsis could be the worst case situation could be urosepsis, which has a high mortality rate. Given the increasing prevalence of UTIs and associated antimicrobial resistance, a high level of diagnostic accuracy for a new diagnostic test is essential. UTIs are a very common pathology. It is estimated that in the Western world, 5% of emergency departments present with symptoms of infection. Every year, UTIs are responsible for just under 200,000 unplanned hospital admissions, which cost the National Health Service within the United Kingdom almost £500 million to treat. The estimated annual cost for UTIs in the United States is around $3.5 billion. Similar in primary care within the UK, 83% of UTI cases are treated with antibiotics without any kind of diagnostics whatsoever, without any screening of the causative pathogen that may be causing the symptoms within a particular patient. 26% of antibiotic treatments are initiated without diagnostics or actually unnecessary. So by implementing the Vivalytic UTI syndromic panel into a centralized lab or non-centralized location, this will allow to improve antibiotic stewardship. And this is one of the key benefits for implementing rapid PCR methods into the lab. Not only are you providing a quicker result, you're identifying the exact causative pathogen, but also allows clinicians to select the correct antibiotic resistance, improving antibiotic stewardship. So the clinical implication of UTIs, you've got your uncomplicated UTI and you've got your complicated UTI. Generally speaking, the uncomplicated UTIs, which are cystitis and recurrent UTIs, present a low risk to urosepsis. However, complicated UTIs, which include the catheter-associated UTI as well as UTI in men, incur a higher risk of urosepsis. This increases the clinical utility of our UTI panel within the Vivalytic. These pie charts indicate the frequency of different pathogens between complicated and uncomplicated UTIs. You will see that most of the highest frequency would be UP E. coli. And with taking E. coli out of the equation, other pathogens include Klebsiella pneumoniae, Enterococcus species, Group B, Streptococcus, amongst others. Uncomplicated urinary tract infections occur when common bacteria infect the lower UTI in otherwise healthy individuals. Any urinary tract infection that does not fit this description is a complicated one. Complicated cases can be longer, cause additional symptoms, and be much harder to treat. Urosepsis can be caused by untreated UTI infections, which may spread to the kidney, causing more pain and illness. It can cause sepsis. This term, urosepsis, describes sepsis caused by a uropathogenic bacteria. Estimated mortality rate of urosepsis is upwards to 20%. This is a very high percentage, which further supports the use of PCR testing for the identification of UTIs in at-risk populations. Common after surgery and after catheter placement. Certain types of surgery increase the risk of infection even further. Surgery takes place in or near the UTI, increase the risk of subsequent UTIs or urosepsis. Surgeries such as kidney transplants, prostate surgeries, and bladder surgeries are well known to increase the risk of urosepsis. So by having a quick turnaround time diagnostic platform for the identification of UTIs are going to be particularly important for these patients rather than utilising the traditional culture method, which may take upwards to 24, 48 hours. In the most severe sepsis cases, this can lead to multi-organ system failure and death. Early identification of UTI, along with proper antibacterial treatment, is the best way to prevent urosepsis. It is possible to develop urosepsis without first having symptoms of a UTI or seeking treatment. Therefore, the rapid detection of UTIs is required for effective patient treatment. Combating antimicrobial resistance. Globally, approximately 700,000 deaths are attributed annually to antibiotic resistance, and this number could increase to 10 million deaths by the year 2050. This is a starking statistic and one that I hope we can continue to develop quick, effective ways of managing and identifying urinary tract infections. Antimicrobial resistance has emerged as a significant global healthcare problem. Antibiotic use has accelerated the physiologic process of AMR, particularly in the gram-negative pathogens. And as it said there previously, our Vivalytic test can detect up to 10 bacteria of gram-negative species and 6 gram-positive species. The risk of AMR and UTI varies in different patient populations, which has resulted in limited therapeutic outcomes. The knowledge of the common causative pathogens in UTIs, including local susceptibility patterns, are essential in determining appropriate empiric therapy, but initially rapid screening is required to first identify the pathogen that is causing the disease. Growing antimicrobial resistance leads to more awareness of reducing antibiotic therapy and the need to implement PCO testing to provide data for AMR and species involved. So more appropriate, streamlined therapy can be provided. So there are a number of different antibiotic resistant markers that have been incorporated into the Randox UTI syndromic panel: trimethoprim, methicillin, and vancomycin. So in relation to trimethoprim, this is one of the most successful treatment strategies for enterobacteria infections. Trimethoprim is a selective inhibitor for bacterial dihydrofolate reductase, which catalyzes the NADPH-dependent reduction of DHF. So by identifying the pathogens that contain this antibiotic-resistant marker, it allows the physicians to decide whether this treatment is going to be used as a first-line treatment or not. And then similar, we have the ability to detect the MEK-A gene for any pathogen that is methicillin resistant. And again, vancomycin A and vancomycin gene can be detected within the pathogens that are prone to mutations in these particular genes. So again, it allows the treating physician to determine which antibiotic is going to be the most appropriate for a particular patient, depending on the pathogen and the microbial resistant markers that that patient sample is containing at the point of sample collection. So current testing for UTIs include the standard urine dipstick, which I'm sure we're all familiar of, but these do lack sensitivity and specificity. However, guidelines suggest this isn't always appropriate. Urine culture where bacterial colony counts vary from 102 to 105 CFUs per mil, and results are available after approximately 48 hours, and sometimes additional time is required, which can extend to up to 72 hours. Given the increasing prevalence of UTIs and associated antimicrobial resistance, a high level of diagnostic accuracy for a new diagnostic test is essential. So using common culture methods as a comparative assessment method. The current workflow for culture, typically for UTI detection, needs up to 3 days. This can involve multiple people and take up to 3 days to not only detect the pathogen, but also conduct susceptibility testing as well. However, by implementing the workflow, the number of processes is significantly reduced, and the time in which the clinician receives the patient result is significantly quicker. The workflow with the Vivalytic UTI needs only a few hours. 150 minutes is the running time on the Vivalytic for the UTI test. Point of care considered an unmet need for UTI management. So here we make reference to a paper published a year or two ago in the Journal of Global Antimicrobial Resistance, a global perspective on improving patient care in uncomplicated UTIs, an expert consensus and practical guidance. UTIs are a common problem in female patients. We know that is a common issue. Management is mainly based on empirical prescribing of antimicrobials, but we know there are concerns about the overtreatment and the abuse of over-prescribing antibiotics to fight infections. One of the questions discussed in the aforementioned paper is what is needed to improve the diagnosis of complicated urinary tract infections. So this particular question is important in relation to point of care platforms that aim to detect and screen for UTIs. And the consensus between the group of experts came to the conclusion that most urgent need is for the development of a PCO test that can both identify the specific uropathogens, but also provide antimicrobial susceptibility data without the need for urine culture. So the Randox UTI panel very much relates to the consensus of this expert opinion. The highest throughput culture tests in labs is for suspected UTIs. However, the standard issues remain. So how has the Vivalytic been utilised in action to show its clinical effectiveness? Well, a point of care study and review was conducted to test for complicated UTIs using the Vivalytic 1 assay with the Randox UTI panel for the detection of uropathogenic bacteria and antimicrobial resistant markers in the urine of urological patients within a point of care setting. In September 2023, a recent study on the Vivalytic analysed 126 consecutive urine samples of patients with a complicated UTI. 40% of these were female and 59% of these were male, with a mean age of 63. Samples processed within the Vivalytic UTI were pre-selected for the presence of bacteriuria by screening with urine flow cytometry with a cutoff of more than 70 bacteria per microliter, and compared to that of standard urine culture and antibiotic sensitivity testing. 19 different bacterial species were detected. 16 species reached a diagnostic accuracy of more than 90%, with a negative predictive value of close to 95%. So some very good statistics here. The Vivalytic was able to detect bacterial species under the estimated concentration of 4 × 10⁴ CFUs per mil. The concordant, that's comparing the Vivalytic versus culture antimicrobial resistance gene detection rate, reached a higher accuracy after transport, up to 84%, compared to point of care testing before transport, with 81%, except for vancomycin. Compared to standard urine culture tests, the Vivalytic UTI point of care test is qualitative, but not quantitative. However, it displayed similar accuracy for uropathogenic bacteria and the antimicrobial resistant genes that were found. So what are the guidelines for UTI infections within the European continent? Urosepsis is defined as life-threatening organ dysfunction caused by dysregulated host response to infection originating from the urinary tract or the male genital organs. Recommendations for the diagnosis and treatment of urosepsis. So you've to perform a quick SOFA score to identify patients with potential sepsis. Take a urine culture and 2 sets of blood culture. Administer parenteral high-dose broad-spectrum antibiotics. Adapt initial empiric antimicrobial resistant therapy. Initiate strong source control, including removal of foreign bodies, and provide immediate adequate life support measures. So for recurrent UTIs, these are recurrent uncomplicated or complicated UTIs with a frequency of at least 3 TIs per year or 2 UTIs in the past 6 months. Diagnosis: recurrent UTI by culture. Do not perform an extensive routine workup. Advise premenopausal women regarding increased fluid intake, as it might reduce the risk of a recurrent UTI, or the use of a prescribed vaginal estrogen replacement in postmenopausal women, and again to prevent the recurrent UTI risk. And also the prescription of an immunoactive prophylaxis to reduce recurrent UTI across all age groups. Okay, well, so continuing on from the European Urological Infection Guidelines, this was last updated in April 2024. So uncomplicated cystitis is defined as an acute, sporadic, or recurrent cystitis limited to non-pregnant women with no known relevant anatomical and functional abnormalities within the UTI. So our panel aims to look at different types of phenotypic characteristics that increase the risk of UTIs in multiple different at-risk populations. The NICE guidelines, which are applicable to the United Kingdom. Guidelines updated in February 2023 for quality improvement in diagnosis of UTIs in women under 65, the review of treatment in asymptomatic bacteria in men and non-pregnant women, duration of use of antibiotics and standards for referring adults with recurrent infections. Highlighting that a standard dipstick testing is not an effective method for detecting a UTI, in particular with patients with catheters and recurrent infections. Instead, signs and symptoms are assessed to diagnose UTIs with urine culture and sensitivity testing used to support the diagnosis and guide treatment diagnosis. So there we have it. The NICE guidelines are stating that a standard dipstick test is not an effective method. So this provides us with evidence to implement additional, more sensitive methods to detect uropathogens, such as PCR methods. Women aged under 65 years are diagnosed with a UTI if they have 2 or more key urinary symptoms and no other excluding causes or warning signs. Asymptomatic bacteria is not routinely treated with antibiotics in men and non-pregnant women because it is not a risk factor for harm. Guidelines now reflect that symptoms should be assessed and identified before a urine sample is sent for culture. Antibiotics should not be routinely prescribed when a urine culture identifies bacteria for a person without symptoms. In older people, symptoms can include non-specific signs of infection, such as delirium. Recurrent UTIs are common, but referral for specialist urology advice is needed when there are higher risks or when it is uncertain if the UTI is the cause of urinary symptoms. Higher risks are associated with recurrent UTIs in men and with recurrent upper UTIs, which can lead to an impaired renal function. NICE also updated their guidelines in 2022 to cover diagnosing and managing UTI infection in infants, children, and young people under the age of 16. So there is an application to utilize our UTI panel across the full age spectrum of patients exhibiting a UTI infection. Pediatric UTIs are becoming more problematic due to increasing levels of antimicrobial resistance, and this may get worse over time. This guideline aims to encourage the appropriate collection of urinary samples, the prescription of appropriate empiric antimicrobials, and the timely chasing of urine culture results. Adoption now includes taking samples from children and young people before they are given any treatment. Clinical statements have been referenced that other markers such as C-reactive protein should not be used to differentiate accurate upper UTIs from lower UTIs in babies and children. The tool should be reduced inappropriate. The tool should reduce inappropriate urine dipstick and culture tests, leading to financial and time implications for labs and primary care commissioners and primary care staff. Standards are reflecting that no testing should be performed before antibiotics are given. However, this is dependent on symptoms and is different between male and female, and only if the symptoms are severe. So very much a case-by-case basis. Culture should be interpreted in parallel to the severity of signs and symptoms. False negatives or positives may and can occur. This is where the appropriate use of quality control should be implemented within PCR, within the PCR testing process to identify any systematic or random errors that can result in false negatives or false positives. Guidelines highlight that you do not treat asymptomatic bacteria unless pregnant, as it does not reduce mortality or morbidity. All of this information, these increased guidelines and all this research has been published from within the scientific community supports the implementation of a rapid technology required to combat AMR. Faster diagnostics allow for more personalized treatment for patients. Emergency and primary care facilities currently do not have the technology to immediately tell if a patient has an infection. Current rapid solutions, such as a standard dipstick test, lack the sensitivity and specificity to identify uropathogenic bacteria and antibiotic-resistant markers to be further evaluated in clinical practice. The features and benefits, once more, of the UTI panel that we're referring to today is that it can detect up to 23 uropathogens, including your antibiotic-resistant genes. It is a qualitative method based on a microarray biochip. The sample material is midstream native urine. The sample volume required is only 300 microliters per test. The transport medium for this particular test, no transport medium is required. The IFU stipulates that native urine is the matrix of choice. The time to result for this particular test is less than 2.5 hours, which is significantly shorter than the current culture methods that are currently mostly utilized in today's clinical setting. So Vivalytic UTI at the point of care. So over the last number of years, we have, with Bosch, we have been undertaking some clinical research studies and publishing the results at European and national conferences such as ACMID, which most recently took place in Barcelona this summertime. In this most recent study, the Vivalytic UTI test displayed high sensitivity and specificity in identifying uropathogenic bacteria and antibiotic-resistant markers. We observed a high degree of concordant pathogen identification at the point of care before transportation. The transport of urine samples influenced the pathogen detection rate and antibiotic susceptibility testing of the Vivalytic UTI analyzer. The UTI panel is a better identification than standard urine culture as well. So why would we wish to implement the UTI panel within the clinical setting? There are multiple other methods in the market, competitors that we may be familiar. But the Vivalytic offers a unique and diverse range of pathogens compared to other methods in the market, with a competitive timing included within that. And it's all contained within the one panel. Other UTI panels may have the main UTI pathogens over multiple different panels, or the panels may be small and limited. However, the UTI panel provided by Randox contain all the key gram-positive and gram-negative bacteria and AMR resistant markers within the single panel. So who can benefit by implementing a UTI point-of-care test within the lab or non-lab setting? Well, we know from this presentation that infants and children, outpatient clinics and gynecology clinics, catheterized individuals with a UTI can deteriorate very quickly if there is no additional comorbidities. Therefore, urgent testing is required, but also urology clinics, those that have got predisposed kidney-related issues, such as those on kidney dialysis, as well as those patients who are immobile, such as those in HDU and ICU wards, long-term healthcare facilities, and those in private care homes, such as the elderly.